whoops, a opportunity to learn about the latest and greatest science, so much as really being sure we all keep up to date about just standards of care. This has been a direct result of our efforts with PCORI and patient-centeredness, and making sure that patients feel that we are offering similar, usually not identical, but similar recommendations across the board. So we really welcome you this evening. And I don't have a lot of intro other than, yes, a couple of other slides. So it's getting late, but we hope you are encouraging your community members to attend the national conference in Omaha. And my understanding is that the registration is gigantic. So that's going to be very fun and entertaining. I think we have another slide or two there. Yes, we hope that everyone is participating in the Osteogenesis Imperfecta Tele-Echo series. And in June, on June 12th, so next Wednesday, Dr. Mercedes Rodriguez-Salen will be talking about pain, which is absolutely one of the leading concerns of our community. And then if you are interested, we hope you're also participating in our rare bone disease tele-echo. If you missed today's talk on fluorosis, I would argue that Dr. White presented a downright shocking presentation as to the high incidence of this bone problem, both nationally and internationally. I hope you'll watch the video, which will be out in a few days, and that you'll think about joining us next month when Dr. Kelly Roscoe from NIH talks to us about calcium sensing receptor disorders. Do I have another slide? And this is Tracy's slide, so I will not speak to this. All righty. Well, Tracy will get to that when it's Tracy's turn. All righty. I think we're ready to go forward then. And it's my great pleasure to introduce Kathy Raggio, who really needs no introduction, but we're certainly pleased to welcome her tonight. Kathy, take it away.
Thanks so much, Laura. Hello, everybody. I am trying to share my screen with you guys right now. And tonight, what I'm going to be talking to you about, let me make sure you can see it. I'm hitting slideshow from the beginning. Is OI the journey of a lifetime? Are we on from the beginning yet? I don't see that coming up. Sorry, my computer, there we go. That looks like I've got you all there. So let me tell you a little bit about this talk, and it's only going to be 15 minutes, maybe a little less. I welcome you all. And the idea is this is a long 45-minute talk. I want to hit the highlights because this talk is what we want people who care for people for OI to know. And we also want, I've given this talk to actually the patients, their families also. So I think it's important, again, as Laura has said, that we're all on the same page and we kind of have a common culture, a common sense of what we're thinking about with OI. And again, this is a little bit of my bias here. I just always put up my disclosures, and always for the fact that those of you who aren't aware is I'm based in New York. I've started OI 35 years ago with Dr. Root, who was at Hospital for Special Surgery already doing OI, and I was able to join him in his practice, and we have now developed a full skeletal dysplasia center where we can treat patients multidisciplinary from birth all the way through to old age, meaning 95 and above. I think our oldest patient is 85 or 87. And so I think that was really the goal here, to go from the child on the left or baby all the way up to the man on the right and even older. So what I'd like to share with you is how I think about OI, and really it's a roadmap. We're going to talk a little bit about what is OI. I think you all know that. So those will be the slides I'll be kind of leaping over. We're going to talk about some diagnosis and treatment. We're not going to get into treatment in the sense of medical, because Dr. Ward will be following, and Dr. Franzone is also going to be following about some surgical, what update on surgical ideas. And then the big thing I'd like to really spend a little time on is transitioning and adult issues, because the adult issues really inform us for care and counseling. As I said, I have the distinct honor to be able to treat people until they age and die. And so I really get to see the lifelong experience of someone with OI. I would like people to have not a caution rough road, but to have a smooth road. And I believe if you know the road you're on, you can plan for the potholes. So even when you hit them, it doesn't seem so bad. That's how I look at it. As you can tell, I'm a commuter, so I'm on the road a lot. So if we talk about first about OI at birth, I think most people are pretty comfortable with this. I think we do pretty good care of the children. We know it's fractures, look at growth, give them the appropriate drugs if needed, watch their bones, watch them fracture, get them PT, get them OT, get them into school. And that's really terrific. Except what happens is when we get to the OI teen group, the teens that we talk to, that they don't really remember what we told their parents when they were sitting on their parents' lap when they were 3 months old. And so I think the take-home message from this is, when you're caring for people with OI, it is important at every age, whether they're 9 years old, 13, 14, to have the discussion with the person who has OI that you are treating, what they have, revisiting it on different visits when they come in, and explain to them, because as the child grows, as that child mentally grows, they are going to bring other things into them. There is nothing sadder for me than seeing an adult who thinks their OI is all about their bones, and the fact that, oh, I haven't fractured, so I must be okay. That means we didn't educate our children and our families well enough to know that actually, you're going to hear me say this a lot, OI is a type 1 collagenopathy. It's really important we remember that. And so transition care and planning is important, because you don't grow out of your OI-ness. And so when I see people who come back to me in their 20s, they're like, oh my gosh, why didn't I pay any attention to this? And how can I kind of maximize me? What should I put into my suitcase to take with me? And what roadmap are we on? Because the goal here is, right now, we know we don't have a cure for OI, but the goal is really to have a better quality of life, and to be enable people to have independence and the quality of life that they so want. And I think that's our message here. So for transition, our goal is we educate, we empower, and we organize, help the person organize what they're going to need going forward. We revisit the diagnosis. We outline the road ahead, knowing the bumps. We identify the caretakers. And at the end, I'm going to show you a slide that says who should be part of their care. And local matters. I think it's really important, and that's why I love everybody being on here, is that we're not trying to drag everybody into major centers. We don't need people flying from, Utah into New York City. We want care to be local, because that's a quality of life issue for people. And clearly the OIF has the resources, all but written by people who we can give out, and we can be helpful. So everything is there. We just have to let people know how to get it. So we all know what OI is. It starts early. We can see it early in pregnancy. Again, I apologize. I'm just going to click over these as I talk. The key message from this one is the type 1 collagenopathy. So it affects multiple systems. One of the systems happens to be the bone, and it leads to bone fragility. But all systems with type 1 collagen in it, type 1 collagen, are going to be affected. You all know that most cases are private mutations, so that it's not like there's one mutation across everybody with OI. So that's important. And the type 1 collagen is in skin, in bone, in your lungs, in your heart, in your eyes, in your ears. So really important. We know it's in the GI system. So it's everywhere. So that's the take home message, that we want to be all on the same page. Though we talk about all these types, type 1 through 4 being the type 1 collagenopathies. And then the other types being things that modify type 1 collagen, or in a different, whole different pathway, but affect bone in the same way. And so that's why I think it's important that we all understand what we talk about. Now, I think you all know that about 95% of people who have OI have the type 1 collagenopathy. 5% are going to be the other type recessives. We know this is very common. We think there's about 50,000 people in the US. It's a very old disorder. It's been around since Egypt time, since the Vikings. And we all have seen people with OI, and so we know what we're looking for, the multiple systems that are affected. The blue sclera, because the light reflects through to the veins in the back. The DI, because again, enamel is normal, but the dentin is abnormal, and so it looks kind of like fig Newton teeth, which is pretty cool. That was coined by Dr. Bulla at my institution, so I like to give credit for fun facts. And then we clearly know that we can have very thin gracile bones that have multiple fractures. We can have wider bones in the more severe forms where they look very crumpled. And so again, a wide spectrum, but again, affecting the bone and affecting everywhere that type 1 collagen is. You all know how to make the diagnosis, and I'm a big proponent that everyone should have their DNA analyzed, because we, as we go forward, hope, what's the take-home message from that, is that we can have more personalized medicine, and that some of the medicines that are out there are going to work better and do work better in certain mutations than others. And so I think it's very important that that piece of information in 2024 is given to the person, and that we know that to help us move forward. The classification, this I'm definitely going to go skipping through, because you should all know the basic Sellens classification, Dr. Sellens in Australia, 1 through 4, and then all the other mutations now. I think we're up to 28 or maybe 29. And so again, moving through this, type 1s, type 2s, 3s, and 4 again. Now, we're all on the same page, and what do we think about in what's important in orthopedics? Since by trade, I don't think we told you, I'm an orthopedic surgeon by trade, but I've done 30 years of research in the laboratory with animal models of OI, as well as working with patients. And so we look at long bone fractures, we look at coxa-vara, we look at protrusio, scoliosis, and basilar invagination. Those are the biggies. What's our management goal? And the management goal is not to treat the x-ray that you just saw. It's to maximize the function of the person. It's to optimize their independence and social integration. And to do that, we have 4 big categories. You're going to hear about medications. Physical therapy, we all know, is a cornerstone. We know about bracing and splinting, and then surgery comes in, and we work together. This is a 4-legged stool. This is not one stands alone, because it doesn't work that way. Okay. I always like to say, generally, fracture healing is not impaired in OI unless we, as surgeons, or we as doctors, interfere in some way. Though we do think there might be some non-unions, we know that, but we have to figure out why that's happening. Okay. All right, physical therapy. Why did we do physical therapy? To stop this vicious cycle of fracture, disuse, osteoporosis. You have to exercise. Muscle mass, muscle pulls on bone. It talks to bone. Bone talks to muscle. If you have weak muscle, you're going to have weak bone. And I tell everybody, that does not mean you have to look like Arnold Schwarzenegger. What it means is no matter what you do, everyone who's sitting still now can be exercising. Exercise does not mean we all go to the gym. Exercise means we work our muscles in the way we can within our bone structure. And whether we're a sitter, whether we're a stander, whether we're a walker, whether we're a runner, we have to work our muscles. So that's really important. Here's a young lady who's getting her therapy in spite of being in a cast. We are relentless. She can get up on her arms. We want to keep them strong, and we want to keep her moving. Bisphosphonates are the medical treatment mainly for children. I'm not even going to say anything about this because we have Leanne Ward, Dr. Ward on, who's the expert. So I'm just going to go right over this. You're going to hear from her. But I think the current treatment in pediatrics is a team approach and bisphosphonates, monitoring everything. And of course, remember, someone with OI is not exempt from getting regular osteoporosis. And so their calcium, vitamin D, everything you would do for osteoporosis in yourself, if you don't have OI or if you do, you need to do for the patients with OI. You do not want to put on OI blinders and forget there's a person with other genes coming to you. Now, we know when we operate for certain reasons, and it's to help get the patient more ambulatory, help them from fracturing through the same area. We know when we do spine surgery, it's fraught with high incidence of issues, but we know that with nowadays, with some new treatments, hopefully we'll be able to be more aggressive. I use that word in quotes to increase their outcomes through surgery. So I'm happy to take any questions on that. And I know Jean Franzone is on, one of our surgeons from Nemours DuPont down in Delaware, and she knows a lot about this. She does a lot of OI surgeries. Okay, so now as they age, we have to remember as people age, what's going to happen is they revisit the fracture risk. And why is that? It's because normal aging leads us to have osteoporosis. And so if you have OI, you're going to get osteoporosis because you're aging, but the threshold is lower because they start from a lower threshold. And so I think that's important to remember that I don't want to say it shifts younger, but I think it does. I think what we think about for an average population, starting when people are in their 50s, we have to think about starting in their 40s, maybe their 30s in people with OI. And again, it goes to fractures, back pain, joint pain, looking at their hips. You really want to look at people's necks. And I think this is a take-home message for everyone on there. You've got to look at the cervical spine because basilar invagination is very common. I shouldn't say very common, is common. I just feel like it's very common because I see a lot of people who have it, but I have a skewed population. And I think when someone comes to you and complaining of headaches, neck pain, weakness in their arms, inability to hold their urine as well, you have to look up to the head neck junction. I think that's really, really, really important. And this is what it looks like. We get an MRI and you can see what looks like the thumb or that little thing projecting up into the skull itself and pressing on the brain. Okay, we know about acetabular protrusio. This is what happens. The cup moves in with people with OI, and it leads to many things, one of which is an increased risk of this particular fracture, which is a femoral neck fracture. And so again, when you want to look for this when you're treating adults, you don't want to write everything off to, oh, maybe you had just a back fracture. You actually want to be aware of, you're looking for an occult hip an occult neck fracture of the proximal femur. But again, that was bony. And I think the real thing here is to remember this is a connective tissue disorder. And the major cause of death in people with OI is respiratory. And we really need to start early getting people to care for their lungs. No smoking, lots of good breathing exercises, and really work hard on that. People used to write it off to the fact, well, okay, look at your back. You've got this huge scoliosis. Of course, your lungs aren't working well. Well, myself, Dr. Sandhouse, who's our pulmonary expert, really worked on this. And what we were able to show, the take-home message from this slide, is that having poor lungs in OI does not correlate with having scoliosis. So you can have a very mild OI and you can have a problem in your lungs. So that made us think it might well be in the collagen itself, because I told you type 1 collagen is there. And we're able to show what I'm pointing to here is the bronchial wall thickening that we see in patients on CAT scans. And so we're in the process of trying to figure this out. But it's important for you to have this awareness when you're dealing with people with OI. And so the way we want to think about this, I'm wrapping up now. I know I've gone over a smidge here, but is you want to think about, for the adults, they need a team approach. We want to think as caretakers about the natural history of OI. And we know now that we are dealing with two different populations of adults. We have adults who have been treated with bisphosphonates since 1994, when Dr. Glorio started this and really helped up and made a paradigm shift for us and for the patients. It was really a change starting from 1994 forward. But now we are 30 years later, and we have people who've been treated. But I have in my population, and I'm sure you do, people who are 50 who never had any treatment as children. So we need to think about that, when and what drug treatments are going to be effective, and our bones might be the least of the problems. Lastly, I just wanted to end, and I know Laura always makes this great point, that you really want everyone, our people, to be involved, our people meaning our patients, to be involved and fill out surveys. That takes the pulse of a group, what's going on. Be involved in a clinical study. That is going to be based on things asked through surveys, clinical practice, and hopefully hypothesis-based. And lastly, there are clinical trials that are sponsored by companies to assess efficacy of the drug. And I think we as caretakers need to keep these in our brain, because we tend to say we do research. Well, not all research is the same. And I think that that's important, and we want to explain that to our patients. As I promised you at the beginning, I would show you a list, as you're transitioning your patients, to think about what they're going to need. And it's really orthopedics. It's going to be endocrine, very important. Genetics, if they do not know what mutation they have. Cardiology and pulmonology, very important going forward. PFTs, echocardiograms. ENT, because hearing loss worsens as they age. Dentistry. Ophthalmology, remember they have a thinner cornea, so when they go for testing for glaucoma, an ophthalmologist needs to know about that. I have to say most of them do. Remember, we don't give up physical therapy. Just because you don't go to a therapist doesn't mean you don't exercise. And we have to be pro bone in our nutrition, and we have to be there to support our patients through what might be their pain and figure out why are they having pain, not just throw medication at them. So on that, I want to end and say we'd like our patients, our people we work with together, to not get at a dead end. And I think the way we do that is that we feel that we are on the trip with the person who has OI, and that it is a great adventure. So on that note, I'm going to stop and turn it back to you guys and stop sharing.
Kathy, that was terrific, and thank you for highlighting so many things I care about. We have a couple of minutes in the agenda for questions, and we would welcome any questions that you have. Tracy, speak up.
If I can unmute myself. No, that was terrific, Dr. Raggio. I think it was, making the point of aging, which is something that we're working really hard on at the foundation. We have a lot of resources. So I know Erica and Kenna will be putting those up as the night goes on here too. That was excellent. Thank you.
Yeah. I mean, I think just to piggyback on that is I don't want you people, I don't want anybody out there to feel that you are alone.
Right.
No, the OI Foundation has worked so hard and has so many resources. We just have to get them to our people, to our patients, and then educate them and then move forward. I think that's so important.
And I would underscore, I hope everyone on the call is aware of the new adult handbook. But if you aren't, it's a must. And I'm finding my patients are very, very grateful, helping them just organize their thinking about moving into adult care. And I believe they are free, correct, Tracy?
Absolutely. Everything is.
We want to share them with you and with your patients. That's for sure. I'm hogging the mic. Would anyone just like to unmute and make a comment or ask a question?
And Dr. Raggio, I know you mentioned Dr. Gloria and he's on the call tonight, so that's wonderful.
Hi.
We're very glad to have you, Francis. That's great. Okay. And if there aren't any questions, we have a lot to cover today. So I asked Jean Franzone to bring us up to date on some very important work that she and others have been doing. I don't see a lot of surgeons on the call, but boy, do I want you to share her information with the surgeons that you work with. Jean, welcome, and thanks so much for being with us.
Yeah, thank you very much, Dr. Tosi, really for this town hall series. It's been absolutely wonderful, and I love that it's widely available after this particular session as well. And thank you, Dr. Raggio. That was a wonderful overview. You got a lot into a short amount of time, which is really terrific. And I think that dovetails very well with what Dr. Tosi has asked us to share this evening. Our specific ask is to share two parallel efforts that are really focused on bringing together orthopedic surgeons who have a strong interest in OI, and these have been going on the past few years. And really the thoughts are the same with both of these initiatives that I'll discuss tonight. By collecting our thoughts and really having an ongoing way to share ideas that overall we can improve the care that all of us give to OI patients, not only in the US, but really around the world, and then foster research ideas and collaboration as well. So the first initiative is based more in the US and North America, and that's what I'll talk about first. This is an OI surgeon quarterly case review, a virtual forum. And I'm really honored and delighted that the three of us shown here on this slide get to do this together. Jill Flanagan is listed first here on the call here as well. And please unmute at the end, both Jill and Megan, to add to what I'll say here. Jill is at Children's Healthcare of Atlanta in Atlanta, Georgia. And Megan Wallace at Phoenix Children's Hospital in Phoenix, Arizona. And we've really enjoyed working on this as a team effort. The idea of this forum, and again, this is a quarterly forum that happens virtually by Zoom. It was really designed and has carried on as a forum for surgeons with a very strong interest in OI orthopedic surgery. And we spend most of the hour reviewing completed cases or upcoming cases. So it's very case-based, which is just a little bit different than the other effort that I'll share. And the cases, no case is too simple to show. There's always something interesting to discuss. And we also have some very, very complex, multifaceted cases, but they're really designed to demonstrate a learning point or seek advice from other surgeons on the call. And these are focused for orthopedic surgeons because there are so many nitty-gritty detailed aspects of the surgery that can really affect outcomes and the longevity of these interventions. And we stress very much that this is a respected environment in which challenges and complications can be discussed. I think OI orthopedic surgeons as a group, or especially those of us who do a lot of it, are probably the most humble because these are particularly challenging cases, and OI bone can have ways of making this very challenging, but also very rewarding. So this is a respected environment and also inclusive. We really encourage folks who have a case to share or want to come listen to reach out, and I'll have our email addresses shown on one of the next slides. So this was one of our very first meetings. You can see Dr. Fassier himself joined, Dr. Esposito, Dr. Cruz. We really had Dr. Hamdi's on here. Dr. Tosi should be, I think she's hiding on here somewhere. Yeah, really, Dr. Raggio had joined as well. Looking around, but you can see lots of, folks who have a tremendous amount of experience and really coming together and sharing ideas. We started this during COVID when, doing things virtually was a little bit novel. But because everybody is scattered all over the country, that's been a great way to continue this. In 2021, our list included 23 surgeons at 16 different institutions, and that's now actually grown to almost 60 surgeons at 38 different institutions. And of course, not everybody on that list is able to log in every quarter, but the invitation is extended to those who are able to make it. And would really like to thank our OIF team for both leadership and organization to take this to the next level of organization. It's been incredibly helpful to have the infrastructure of the OIF and really help us keep track of these meetings and our list. So thank you very much. This particular meeting happens Wednesday evenings, usually from 8 to 9 p.m. And again, this is by Zoom. A couple examples. This is a very challenging elbow case. This is a patient with type 5 OI who is having elbow issues, and there's a lot of facets to that discussion with the hyperplastic callus. This is a challenging non-union in a patient with one of the more rare forms of OI, and certainly need a lot of thoughts on how to manage these complex cases. Another example of a case discussed early on, and then as Dr. Raggio had pointed out, the acetabular protrusio and femoral neck fractures can be very challenging. So these are examples of things that we might discuss in this forum. This was our most recent meeting just a few weeks ago. Again, really discussing cases, an open discussion, and lots of good ideas that have come out of this. And then another couple examples of challenging cases that have been presented, and sort of discuss the ins and outs of how to do these complex procedures, and another few examples here. And the neat thing is oftentimes when somebody shares a case, a few of us sit there and think, oh my goodness, I've had just about exactly the same case or very similar. And this is, really broadly applicable at times. So if we've drummed up enough interest, please jot down our email addresses. Again, this will be available. And you could also always reach out to the OIF, and then the team will get a hold of us. So that's the US based, or really North America based group, because we have quite a few Canadians as well. Another somewhat parallel initiative that we've been doing in the orthopedic surgery realm is a slightly more internationally based OI surgeons. We call this a study group because it has a bit of more of a research flair to it. And Dr. Cruz, my senior mentor, was really instrumental just a couple years ago, about 3 years ago, in bringing together folks really from all over the world, most of whom are at fairly large OI centers in different countries, and really bringing together this wonderfully diverse and talented group of surgeons. We now have about 40 surgeons in 17 different countries, which I think is a great reach around the world. We're always looking to grow. And again, the OIF has been really instrumental in helping to facilitate these sessions, and we're very grateful for that. And I really think these are powerful ways, again, to share ideas on an ongoing basis and ultimately help improve care. The challenge with this meeting, as all of us know who do international meetings, is finding a time. And there's no perfect time. We've been doing them on Wednesday mornings. But again, it also generates an email list that can be used to share thoughts at other times as well. We have a meeting upcoming in July. This group is not purely case-based. It tends to be a little bit more topic-based, with cases tied to a particular topic. And Dr. Cruz recently administered a poll to the group to really help guide our priorities. And the top three that we came up with are discussion of clinical cases, because that's very important, collaborating on research, and that will probably be sort of subgroups of this international group. And then ultimately, with the power of a group like this, being able to work on consensus development and some clinical lecture series. This was one of our very recent meetings. And again, it's fascinating, when you branch out to surgeons all around the world, the resources available can vary very much. The clinical care environments vary, the surgical approaches, and then there's also some very strong similarities. And it's been fascinating to learn from the experts in this group and really help push care forward. These are some examples, again, of topics or cases that we've discussed, acetabular protrusio being one of them, various challenging cases, and then non-unions as well, which can be a challenging clinical concern for a subset of our OI patients and families. So again, with interest in this group, you could certainly reach out to either Dr. Cruz or to me, and or to the folks at OIF. And I think the other reason to present these is this is not limited to orthopedic surgery. I believe some of the endocrinologists and other medical folks who take care of OI patients have made a very similar group. And I think the model is certainly more broadly applicable. These two are very tied to orthopedic surgery, but I think the model is certainly more broadly applicable as well. But I welcome any questions or thoughts. And I know I did see Megan and Jill on. If you have anything to add, please jump in.
No, so this is Jill. I think obviously Gina, I think, did a great job of summarizing what we're doing. And again, I just wanted to echo thanking the OI Foundation for all their support and helping keeping us organized. I'm proud to see this list growing and growing, and the complexity of the cases, at least on the surgeon side, is getting higher and higher. And we're seeing the fruits of our labor too. So it's been very educational, I think, for everybody. So thank you.
That was great. Jean, thank you very, very much. Jill, welcome. I think Megan's on board here today. And I just think it's so great that the three of you have brought this forward with so much energy, because it has been eye-opening. There's no such thing as an easy OI case. Would be what I would have to say on this particular topic. And if anything else, if nothing else, it's a relief to see that I'm not alone. You know, every child has some new thing to make me feel bad about. But that's okay. And we're doing better and better at what we do. That's for sure. Last chance for questions, folks. Be sure you get that those connections for your team members if you aren't doing it yourself. Great. Thanks so very, very much.
Thank you.
All right. Next. I cannot believe how things have changed when it comes to bisphosphonates. And I would argue that there are just a few people who've really worked hard at chronicling the change, measuring the change. But Leanne Ward has certainly been right at the forefront. And Leanne, we're so glad to welcome you today. And she's going to talk about bisphosphonates for OI, principles and protocols, evidence and experience. Welcome aboard, my dear.
Thank you, Laura, and so great to see everyone. You've got a really great crowd out tonight, and I'm really delighted to be here and to talk about this important issue. I'm just going to fire up my slides here. There we go. Just let me know when those are loaded. Can you guys see my slides? Still loading, I think. There we go.
You're
Thumbs
good
up?
now.
Good? Okay, great. Super. Yeah. So Laura really wanted me to sort of get into some of the practical aspects of bisphosphonate administration. So that's what I've put together for you this evening. And I will just start with my disclosures. I am heavily involved in therapeutic trials for children with a number of rare bone disorders, including OI, with funds to my institution. I am a pediatrician, so I am going to be speaking from the pediatric osteologist's perspective. And all of the osteoporosis therapies that we'll be talking about this evening are off-label for children in the Americas. To my knowledge, Noridronate is approved for the treatment of OI in Italy, and Pamidronate is approved for the treatment of OI in Japan. If there's other worldwide approvals, you can educate me, but these are the ones that I know about, but not in the Americas. We're going to really be talking about children's bone, as I said, but I do want to draw your attention to this wonderful approach to the patient article. So the Journal of Clinical Endocrinology and Metabolism puts out these ATPs, and this is on the approach to the adult from a pharmacological perspective with osteogenesis imperfecta. So that may be something you're interested in reading about. So these are the questions that Laura wanted me to tackle: who to treat, which agents, dosing regimens, when to stop, safety issues, surgical considerations at the interface with medical therapy, and then also to have time to discuss your questions and hear about your experiences. And as Kathy said in her talk, the goal of treatment is really to enhance mobility and to improve quality of life. So although we're talking about fractures and vertebral body reshaping and bone tissue effects, ultimately what we're trying to do is to keep these kids moving and as pain-free as possible. We've gotten a lot of mileage out of bisphosphonates. They're pretty much all that we've got, although that may be changing, but as of now, June the 6th, 2024, they're still all we have. And so we use them a lot. And I think we've really learned over the years how to use these medications as effectively as possible. When we make our decisions, there's no question that we draw on principles of bone biology and the way that these agents impact the structure and the density of the skeleton. We think about care pathways, we think about the evidence that we have at our disposal to make our decisions, and then experience. So I'll be talking about all these aspects this evening. Let's start with some general principles of anti-resorptive therapy, bisphosphonate therapy in OI. So of course, bisphosphonates are taken up by the osteoclast at the time of resorption by this beautiful ruffled border. And in so doing, they interfere with a process known as protein prenylation, which is the way in which the osteoclast maintains its shape, including that wonderful ruffled border. And they specifically inhibit farnesyl pyrophosphate synthase. So the bisphosphonates essentially stun the osteoclast. When you look under the microscope, the osteoclast is not apoptotic. It hasn't disappeared, it's still there, but it's very sick and it's bloated and it's lost its ability to resorb bone because it's lost its shape and thereby ruffled border. Now, all that we've learned about the bone tissue response to bisphosphonate therapy in the growing skeleton has essentially come out of the Shriners Hospital over the years, Francis Glorieux and Frank Rauch. So when I review these principles, I'm really talking about their work over many years. And I think it is really important to understand the way these drugs work on the developing skeleton, which is unique compared to when we give the medications in adulthood. And I built this for you guys. I just wanted you to have a little fun this evening with this slide. So Frank shared this with me many years ago. And on the left, this is what happens when children are growing at the cortex in the absence of bisphosphonate therapy. So the osteoclasts are chiseling away the endocortical surface, and the osteoblasts are unlinked from the osteoclasts on cortical surfaces, which is different than on trabecular surfaces where they're linked. And so on the exocortical surface, in the absence of treatment, the osteoblast is just doing its thing. And you get, as the bone gets bigger in width, you have a net change in the cortical width. But in the presence of bisphosphonate therapy, the osteoclasts are shut down, so you do not have endocortical resorption. The osteoblasts are unlinked from the osteoblasts are unlinked from the osteoclasts on the cortical surface. And so as the bone gets wider, the cortex also gets thicker. And this is the main mechanism by which bisphosphonates make bones stronger in childhood. And we see that on transiliac biopsies. So this is nicely shown here in a child who started bisphosphonate therapy at a young age. And a couple of years later, there's this substantial cortical thickening to the tune of 88%. The trabecular bone volume has also increased, but even visually, you can see that it hasn't increased dramatically. So we know that the cortex is what's being modified the most here. The trabecular bone volume increases are largely driven by increases in trabecular number, but not in trabecular thickness. And so why is that? So in the absence of treatment, without bisphosphonate therapy, the growth plate matures to form primary spongiosa and then eventually secondary spongiosa, which still has cartilage in it. And those secondary spongiosa eventually become mature trabeculae. When resorption is going on normally on the left in the absence of treatment, then those primary spongiosa, most of them get resorbed and only a few survive. But with bisphosphonate therapy, more primary spongiosa survive because of the absence of resorption or decrease in resorption to become secondary spongiosa, which have lots of calcified cartilage in them as they're on their route to becoming mature trabeculae. And so this is the mechanism by which trabecular bone volume increases to some extent in terms of an increase in trabecular number. And under the microscope, we see that the trabeculae retain calcified cartilage. And this is dense material, and that's part of the reason why the bone density goes up so much on bisphosphonates. Whether it's as strong as bone is a different question. And those trabeculae line up in a horizontal pattern with retention of their calcified cartilage, and that gives us the zebra lines at the distal metaphyses, also at the iliac crest. And what you're seeing here is the lack of resorption that's frozen the bone at a certain period in time. So growth plus anti-resorption, 1 + 1 = 3, and that 3 is an increase in cortical thickness and trabecular number. And this is why it's so very important to treat during childhood, because you have the synergistic effect of anti-resorption and growth, giving these significant structural improvements. This is the inaugural paper, of course, that taught us that bisphosphonates are helpful to children with osteogenesis imperfecta. This is Francis Glorieux's landmark work, and you can see that BMD just going up in a precipitous fashion and evidence for vertebral body reshaping even when the vertebral bodies are significantly collapsed. We know that it's important to start bisphosphonates early because vertebral body reshaping takes time. This is a growth-driven process. The bisphosphonates are supporting the BMD so that growth can have a permissive effect. But it does take time. So if you wait until a child is 10, 11, 12 with advanced collapse, then you'll run out of time to see those vertebral bodies reshape. And here's what it looks like a little bit closer up, and you can see nice densification of the end plates here in this patient. But again, look at how many years have gone by, 6 years to go to this vertebral body on the right, and it's still not completely square shape. Now, Frank Crouch's group, looked at the fate of vertebral bodies in patients with OI who were started on bisphosphonates less than 5 years of age and who were followed until final height for a median of 15 years. So you're looking at the evolution of the spine over a 15-year period, and 83% of initially compressed vertebrae normalized in shape. And this is one of the main advantages of bisphosphonates in OI, is the extent to which it protects the vertebral bodies, and some nice examples here in OI type 4 on the left. Bisphosphonates, when given at a young age in OI, also bring about reshaping of the cranial vault. Kids with severe OI, of course, are very flat, and I have patients who the back of the skull is so flat they can't turn their head, they can't get over the ridge that's created by the flatness, and we actually give them a very, very ultralight helmet, because they're very light these days, that just allows them to turn their head. And it's amazing how they start to interact with their environment when they can start to see left to right and all around. And so bisphosphonate therapy hastens this reshaping of the skull. What about long bone fractures? The long bone fracture reduction on bisphosphonates is about 50%. Right? So 50%, not a bad number, but it's not good enough, is it? We need to be getting farther with medical therapy. And of course, we hope that some of the anabolic antibody therapy will help with that. And I'll talk more about that in a minute. But this is some of the evidence to show that there's a fracture risk reduction after starting bisphosphonates at the long bones, but that fractures do continue. And so when I speak to families about starting bisphosphonate therapy, I say, look, we're going to do a pretty good job of protecting the spine. And because your child is young with OI, we expect the vertebral bodies that are already compressed to reshape to some or a large extent. But the long bone fracture rates, although we're decreasing them by about 50%, we are still going to see long bone fractures, and that is an unmet need. So I manage expectations when I start bisphosphonates, so they don't think that the presence of a long bone fracture after starting a bisphosphonate is indicative of treatment failure. It's not as black and white as that. Why are the long bones more refractory to bisphosphonate therapy than the spine? So remember that anti-resorptives are bone density modifying agents. That's what they do. And the spine and also the hip are largely composed of trabecular bone, and trabecular bone is porous. So there is a significant bone surface on which the bisphosphonates can act. Remember, bisphosphonates have to hone and act on bone surfaces. But cortical bone, also known as compact bone, is not as porous. So there is not as much surface area upon which the drug can act, and you simply do not have the same room to improve bone density. And then on top of that, in many cases of OI, the long bones are gracile, they're thin. And so a thin pencil is going to be more fragile than a thick pencil, for example, of the same density. And bisphosphonates do not alter the periosteal circumference of bone. So that is not something that we can look to with anti-resorptive therapy. Now, this is a slide that I actually put together for families when I talk to them about anabolic antibody therapy, just so they understand what I'm saying. So you can see very porous bone, lots of surface area upon which the bisphosphonates can work. On the left and on the right, long bones, compact. You just can't modify bone density as much. Plus, the bones are often gracile. So what about the evidence for what we do with bisphosphonate therapy in OI? Of course, there's long been the oral versus IV debate, and I think we all understand that IV therapy is considered first line. It's much more potent than oral therapy, and that IV is better than oral therapy on balance, but oral therapy is better than nothing. There have been a number of randomized trials looking at oral therapy in OI. So in the late 90s, in the turn of the century, those of us working in the field said, okay, we've got, IV bisphosphonate therapy as an option, but wouldn't it be nice if we could use oral agents, more convenient for the families? And so a number of trials went on, including one that I did in about 150 children with OI on alendronate daily versus placebo, and the bottom line is we just didn't see the same results that we did with IV. Now, IV and oral have never really formally gone head to head in a large trial setting, but we know that with IV therapy, we do see these important structural changes at the bone tissue level, and we also see quality of life indicators improve. So this is what we know about IV and oral therapy on balance. Oral therapy, no question, it's more convenient. The bioavailability is less than 1%. Less than 1% of the drug that you give orally makes it into bone. We do see increases in BMD, and oral agents may reduce long bone fracture rates. Nick Bishop showed that in his Resedronate trial, but it was unclear in that study whether major long bone fracture rates were reduced, i.e. femur fractures. And then IV bisphosphonates, although largely observational studies, we do know from those carefully done studies, many of them out of the Shriners in Montreal, where children were very carefully phenotyped longitudinally pre and post IV bisphosphonate, that in addition to increasing BMD, they facilitate rod insertion, they reduce long bone fracture rates by 50%, as I said, they increase cortical thickness, as I said, if the patient is growing, they reduce incident vertebral body fracture rates, and they foster vertebral body reshaping, they improve grip strength, and they do have a beneficial effect on pain for most patients. But there are a number of considerations. So it's not a black and white dialogue with IV bisphosphonate therapy. The nuances are that indeed, these are very potent agents that do reduce bone turnover. And of course, how active a bone is important in how it responds to microtrauma and overt trauma. So I'm going to talk about that. There have been questions over the years about atypical femur fractures on bisphosphonates in OI. I'll address that, ONJ and delayed osteotomy and fracture healing. So we're going to discuss these points. And then cessation during growth increases bone fragility at the treated and untreated interface. There's significant first infusion side effects with IV, and questions about optimal dosing and interval timing and effects of treatment discontinuation persist. So I'll discuss that with you. And these agents do not increase periosteal circumference, as I said. So I'd like to unpackage these considerations because I think this is what, Laura, you really wanted me to dig into tonight. So here we go. So do bisphosphonates cause atypical femur fractures in children with OI, or do femur fractures in children with OI have atypical features? Of course, the definition of an atypical femur fracture is very precise. It's been put forward by the ASBMR. The features include that the fractures are distal to the lesser trochanter, but proximal to the supracondylar flare of the femur, no or minimal trauma, transverse or short oblique, non-comminuted, through both cortices with or without a medial spike, or through the lateral cortex only. So those are the specific criteria to say that a patient has an atypical femur fracture. Another lovely study out of the Shriners Hospital in Montreal. This is a study looking at 165 femur fractures in children with OI. They removed those that had deformities, so they were left with 36 femur fractures without deformities. 11 of those femur fractures happened on bisphosphonates for a atypical femur fracture characteristic rate of 27%, 25 femur fractures with those atypical features, 25 femur fractures occurred without bisphosphonate therapy, of which 8 had atypical femur fractures for a total rate of 32%. So in other words, the atypical feature characteristics occurred more often in the patients who were bisphosphonate naive compared to those who were treated with bisphosphonates. And then further analysis showed that the atypical features were related to disease severity and not to bisphosphonate treatment. Around the time that this study was coming out of Frank Rauch's lab at the Shriners, Auti Makiti showed the same thing, very same thing, using a more saltatory approach to bisphosphonate therapy, not a continuous approach, but with breaks in bisphosphonate therapy. And she came to the very same conclusions, that bisphosphonates did not lead to atypical femur fractures per se, because they occurred more frequently in the patients who were bisphosphonate naive. So I have socialized that instead of children with OI having atypical femur fractures, they have femur fractures with unusual features, or FUFs. So that's just my little proposed new entry into the dictionary. What about bisphosphonates? Are they linked to osteonecrosis of the jaw in children in general, let alone osteogenesis imperfecta? We've gone looking for ONJ for years. When I first left the Shriners and went and set up my own practice in Ottawa, I did panoramas of the jaw, and then I repeated them 2 years after starting bisphosphonate therapy. And then after about 6 years of doing that, my nurse came to me and said, you know, Leanne, do you really want to keep doing that? Because we haven't seen a single case. And in the published literature, there isn't a single case. So it does not appear that ONJ is a pediatric phenomenon. And why is that? Probably because the jaw is younger, right? The bone is more dynamic and children are not as prone to alcoholism and smoking and the other things that can erode jaw health. That doesn't mean to say that we don't take care of this, that we tell the families, if you need to have teeth out, best to do it before you start bisphosphonate therapy. Must keep good care of your teeth while you're on bisphosphonate therapy with dental appointments every 6 or so months. So we still message that, but this does not seem to be a pediatric phenomenon. Now, that said, there is a case report in the literature, not in OI, but in Duchenne, of a 26-year-old male who was on deflazacort for 19 years and oral alendronate for 11 years. He had tongue hypotonia and couldn't clear his secretions, and he developed ONJ without even the extraction of a tooth. So it isn't to say that this can't happen, but here we're seeing a situation where the risk factors for the ONJ are stacking up against the patient. Hypotonia, not clearing secretions, glucocorticoid therapy, which suppresses bone turnover, etc. What about fracture and or osteotomy healing? There is no good evidence that bisphosphonates delay spontaneous fracture healing. That isn't to say that you can't have non-unions, but on balance, it does not appear that this is a significant problem on bisphosphonates, but osteotomy healing is delayed on bisphosphonate therapy. Another study out of the Shriners Hospital, here's an example. They defined delayed osteotomy healing as lack of complete healing after 12 months post-surgery. And this is in a young patient who started zoledronic acid at a year of age. So the surgeons of the Shriners said, well, what can we do to improve this osteotomy non-healing rate? So they moved from a SAW to an osteotome, and they also delayed bisphosphonate reinitiation to at least 4 months after surgery. And so with a SAW, you're disrupting the vasculature as well as cutting through bone. And that vascular, of course, is enriched with all kinds of healing promoting markers. Whereas an osteotome, you're shearing the blood vessels, but you're not interrupting the blood supply. So that's the thinking behind the osteotome. And then the 4 months seems to be the interval that it takes for these osteotomies to heal. And so you're looking at a delay of about 4 months. Now, I also go to my surgeon at the 4-month mark and I say, are we ready? So I don't just leave it to 4 months, black or white. I talk to the surgeon and together we look at the x-ray and decide whether it's okay to go ahead. Some patients may need a little more time and some patients may actually get away with a little less time. So with that approach, then the frequency of delayed osteotomy healing at the Shriners Hospital decreased from 72% delay to 42% of lower extremity osteotomies. And the bone that's most at risk is the tibia. And the patient risk factor for delayed osteotomy healing is an increase in weight. So there are some patient features that are contributing to this phenomenon even beyond bisphosphonate therapy. And so here's an example of a nice osteotomy that has healed 7 months later using an osteotome and delaying bisphosphonate reinitiation for 4 months after surgery. Now, what about protocols? So I just remind everyone, especially since there's surgeons on the call, that as medical doctors, we have to keep in mind that unless we do something to correct that bowing deformity, it doesn't matter how much bisphosphonate we pour into that patient, they're still going to fracture. And I think this is important because I have had physicians reach out and say, I've got a child with OI with recurrent femur fractures, not sure if it's the right zoledronic acid dose, should I be giving more? And we look at the x-ray and there's significant deformity. So this speaks to the importance of the collaboration between the surgeon, the medical osteologist, and of course, PT and OT, as Kathy mentioned in her talk. I also want to say that we also have to keep in mind that it's not just fractures that can cause pain, that there's an increased frequency of spondylolysis and spondylolisthesis in OI. So when I have a patient with low back pain, sure, I'm looking for a progressive vertebral fracture, but I'm also looking to see if there's other causes of back pain that I need to take into consideration. Now, when do we treat? I don't think anybody would argue that it's reasonable to treat a single low trauma femur, tibia, or humerus fracture in OI. I think we would all agree that it's reasonable to treat a single vertebral fracture, or even an asymptomatic vertebral fracture, if it meets fracture criteria of more than 20% loss in vertebral height. I think where the controversy exists is on the forearm fractures and the hands and the feet. And so there, I think it requires some judgment. If you have a child with OI who has a low trauma forearm fracture, who has a flagging bone density and bone pain, this isn't a child that I would sit on. This is a child that has an osteoporotic phenotype and I think would benefit from early initiation of bisphosphonate therapy. Some clinicians wait till there's 2 forearm fractures. And again, I just think it's not black and white and that it's a bit of a nuanced appraisal of the patient's overall clinical trajectory. And then hands and feet fractures, I mean, we usually wait for more than one, but at the same time, we can't underestimate the importance of a finger fracture in the life of a child with OI or the importance of a metatarsal fracture. So again, I'll look at the whole picture. I'll look at the age of the child. I'll look at the bone density trajectory. I'll look to see if there's background pain, how mobile they are. We know that children feel stronger on bisphosphonates in terms of muscle strength. So I have a low threshold for initiating bisphosphonate therapy in OI because I know that early treatment portends more favorable outcomes, and I know that they'll feel better on it. This is the inaugural protocol out of Francis Glorieux's group all those years ago in the 90s, and this has been circulated around the world using pamidronate, which is a 3-day protocol in terms of the original version. There's also zoledronic acid, and people say to me, am I disadvantaging my patient by using pamidronate instead of zoledronic acid? And I think the answer to that is no. The only real advantage to zoledronic acid, to my mind, is that it's a 1-hour instead of a 4-hour infusion. The pamidronate actually may be associated with a little bit gentler first infusion side effects. Either way, the goals of therapy are the same: to improve pain, to get the children walking, to prevent incident fractures and get them out of the fracture-refracture cycle. This is a study by Wolfgang Hugler's group that showed that zoledronic acid is actually less expensive than pamidronate because it is a shorter infusion time, so that may be another reason to use it. This is a protocol out of a chapter or a article that I just wrote that talks about when to initiate therapy and how to titrate doses. And I just refer that to you if you're interested, but I'm going to talk a little bit about dose titration now. This is Frank Rauch's protocol for dose titration, and it is published, and you can see that he starts with zoledronic acid, 0.05 milligram per kilogram, which he gives every 6 months. He starts with a lower dose with the first infusion, but then it's 0.05 mg per kg every 6 months. And then if the BMD Z-score at the spine is over 2, then he goes down to 0.025 every 6 months. And then if the BMD Z-score is over 0, he goes down to 0.025 every 12 months and continues till the end of growth. So that's one protocol that is in use and that works well. But I just want to nuance a little bit the optimal dose and the optimal interval between infusions with a couple of patients that informed how I think about this space. So on the left, this is a patient with osteogenesis imperfecta type 1. And he had vertebral fractures as his main indication for starting bisphosphonate therapy. And I did a transiliac bone biopsy 3 years after starting zoledronic acid, and he had corticalization of his trabeculae. He had so much anti-resorptive activity going on that he had corticalization of his trabeculae with very little marrow space. Although his CBC was normal, he had this spectacular increase in his lumbar spine BMD. But I said to myself, this patient was on 0.05 of Zol every 6 months. I said, I don't think I quite need that big dose. I think 0.025 milligram per kilogram every 6 months would be sufficient. And that became the go-to dose that I have used ever since. And I only go up to 0.05 milligram per kilogram if a patient is not thriving on the 0.025 milligram per kilogram. Around the same time as I was experiencing this with this patient and other patients, Laura Bachrach published a paper looking at a pimidronate half-dose protocol in children with osteoporosis in general. And she also concluded that clinical outcomes were satisfactory on a half-dose protocol and proposed that that was a reasonable route to go in order to avoid excessive bone anti-resorption. So we now think of bisphosphonates as having a stabilization protocol, which is anywhere between 0.05 to 0.1 milligram per kilo per year, and then dividing that every 6 months. And then the maintenance protocol, once you've got the patient settled down, if you will, get rid of their pain, get them out of the fracture refracture cycle if that's relevant. And then you go to a half dose protocol after that. Now, this was published out of the Shriners looking at the efficacy of a 2/3 dose pimidronate protocol, 6 milligram per kilo per year, instead of 9 milligram per kilo per year pimidronate, which was the original protocol. And they were interested in looking at the serum creatinine, actually. And they found that the creatinine was similar on the modified as well as the full dose protocol, and that the lumbar spine BMD Z-score increase was actually a little bit higher on the modified, the 2/3 dose protocol. Now, the numbers were not huge in this study, so I don't think we can say that lower doses give rise to a greater increase in BMD, but I think we can conclude that the lower doses do not seem to be compromising the increase in BMD. So this is my approach to zoledronic acid. I use 0.0125 milligram per kilogram for the first dose, and then 0.025 milligram per kilogram Q6 months. And then I increase that dose to 0.05 milligram per kilogram every 6 months if there is an insufficient clinical response. If BMD isn't going up satisfactorily, or if they continue to fracture, the vast majority of patients just stay on the 0.025 milligram per kilogram every 6 months. I go down to 0.0125 milligram per kilogram if I have an excessive BMD response. So I'm looking for a normal rate of BMD accrual for age, sex, and height, plus satisfactory clinical outcomes, including pain, fracture rates, vertebral body reshaping, and mobility. So I'm really looking at the whole picture with longitudinal phenotyping to assess the adequacy or excessiveness of my doses. Now, in children under 2 years of age, we give 0.025 milligram per kilogram every 3 months because of the high bone turnover of rapid growth. And then between 2 and 3 years of age, we transitioned every 6 months. And I just want to say that I don't just do that automatically at 2 years of age, like turning on a faucet. I think about it. I see how they're doing. Some patients between 2 and 3 years of age, as they're transitioning from that rapid growth to the more quiescent growth phase, still need it every 3 months. So I look at how the patient is doing, and then I make that transition at a time that is reasonable for their bone health trajectory. And usually that is by 3 years of age, but not necessarily automatically at 2 years of age. Now, the treatment discontinuation story is quite interesting. What happens if we give drug holidays during growth? I just love my blast class, so I did this slide for you guys as well. The drug holiday situation is interesting. So when you stop bisphosphonates and you're still growing, the newly formed bone is untreated and goes back to its original low density. It's genetically determined low density. And you see this bone within bone at the spine after you stop, and you see this newly formed bone adjacent to the growth plate at the distal metaphysis that's also much lower density. And so, not surprisingly, you've got a density differential here, which is called a stress riser, and this can be associated with fractures at the interface between the previously treated bone and the newly formed treatment-naive bone. And Frank actually measured this. So on the top left, this is a 12-year-old girl with OI type 4 after 6 years of pimidronate, and he did a slice through her distal radius, and the trabecular VBMD was plus 2.6 while on pimidronate. And then the drug was stopped and the newly formed bone was low density. He went back to the very same site in terms of its proximity to the growth plate. And the trabecular VBMD Z-score was minus 3.2. So that's a huge density differential, right? 5 standard deviations. And then, of course, we see the fractures at the interface between the two. And interestingly, Craig Munns has actually quantified the difference in the density through a zebra line compared to the adjacent bone, and it's a difference of about 126%. And he shows you this zigzagging bone density in this publication. And he argues that this observation of a huge density differential between the zebra lines and the adjacent bone and fractures occurring at the interface between the treated and untreated bone provides a rationale to give frequent low doses in children with osteogenesis imperfecta or other diseases with persistent risk factors. So for this reason, I'm not a big fan of annual infusions, and I like to keep the children while they're growing on more frequent infusions every 3 to 6 months, but I do recognize that annual infusions can be more practical. And then when you stop bisphosphonates after growth is finished, Mary-Eve Robinson, working with Frank and Francis, has shown that fracture rates are lower after stopping than they were on treatment. And that's probably because the skeleton is no longer at risk of fracturing simply because of growth. As bones go longer, there is a lag between growth in length and densification. And so growing is actually a risk factor for fractures. So things settle down for patients with OI if you stop bisphosphonates after they finish growing. And then finally, just first infusion side effects. We have to take care of these, and I know that everyone is accustomed to doing that. There is a publication, again, out of the Shriners showing respiratory distress in an infant who received the first dose of pamidronate. And I recently received an email from somebody out in the world who's had an infant experience the same thing. Ultra rare, I've never seen it, but it has been shown to happen. And there's some theories on why you might have respiratory distress on bisphosphonate therapy, even beyond the thoracic cage abnormalities. So it might be something you might be interested in reading about. Going forward, what are we going to do about this small bone size? Well, of course, we're hopeful that anabolic antibody therapy, anti-sclerostin antibody, which works on all 4 bone surfaces and makes the rat's long bones bigger. We are hopeful that this is going to improve fracture rates in OI. Those trials are underway. So anti-sclerostin antibody releases the inhibition on bone formation and does have anti-resorptive effects as well. So I feel we've got a lot of mileage out of bisphosphonates. I think we know what to do with them now after all of these years of study, starting with that inaugural publication in the 90s by Dr. Blochieux, and then the phenomenal papers that came out of the Shriners over the years in terms of the bone tissue effects and clinical effects. And the question is now, can we improve on the therapeutic landscape by moving into these anabolic antibody therapies? And so I appreciate your time this evening and the opportunity to have spoken to you, and really interested to hear your thoughts on what I've said this evening. Thank you.
Fantastic. And I hope you'll all feel free to just break in. And very thoughtful. So what I didn't understand, you've lowered your dose, and are you doing it over 3 days still, or are you just doing 1 day? 3 day has been very difficult for all of us.
Yeah. No, thank you for that. So let me just be ultra clear. So I don't use pamidronate anymore for OI. After a few years of doing the 3-day infusion protocol, my institution said in about 2010, Leanne, you've got too many patients on bisphosphonate therapy. You have to do something about it. And then zoledronic acid was starting to come out. And so I switched to zoledronic acid. The only time I use pamidronate in my practice now is for a very sick child who's medically fragile. Cancer patients occasionally, it's almost 95% Zol now in my practice, and all patients with OI get zoledronic acid unless they are really a sick newborn, and sometimes I'll use pamidronate, but even then you can use zoledronic acid. So with pamidronate, I use the half dose protocol. If I'm going to use it in these medically fragile situations, I use 4.5 milligram per kilogram. The Shriners has published 6 milligram per kilogram, so 2 milligram per kilogram at a given time, and then giving that every 4 months, or 4.5 milligram per kilogram per year is the other protocol, dividing that up every 4 months. And then zoledronic acid, I use a half dose protocol, 0.025 milligram per kilogram. And I rarely have to go up to the full dose of 0.05 milligram per kilogram. I know that other people do different things. I know a lot of people also do what I do. And I think it's what experiences you've had, how precipitously you've seen the BMD go up on full doses. I just don't think we need the full doses in most of the patients, and that has informed my protocol. And I do, I am concerned about over treatment, and the BMD is always the guide. So if you're not giving enough bisphosphonate, the patient will tell you the BMD isn't unfolding as it should. The fracture rates aren't settling as they should. But 0.025 milligram per kilogram every 6 months seems to be a sweet spot.
And how often are you doing your DEXAs?
Every 6 months?
Great. I'm so glad to hear that. I sort of felt I was overdoing it, but I just get nervous waiting a whole year. Great.
Yeah.
This is Francis Glorieux. May I say something?
Sure, of course.
Okay. It was an absolutely superb presentation, Leanne. Thank you so much. Thank you. I just want to make 2 points. One, considering the osteonecrosis of the jaw. The dose that was used in patients who, for various reasons of bone disease, receive massive dose of zoledronic acid is the reason. I looked at that for treating, a metastases of any kind. They used the ZOL, but the ZOL at 20-30 milligrams per kilo. So it's really a massive dose of ZOL that is used, and compared to what we use in our children, and those really block and cause the osteonecrosis of the jaw. My professor of pharmacology used to say, when I was a medical student, the only difference between a poison and a drug is the dose. And it really is what happened here. And that's why we don't see it, because we use those that had much less that is used in other medical situations. And the second point I want to make is concerning the anti-sclerostin, the JBMR paper, the asteroid, has been accepted by the JBMR yesterday. So it's now in the literature. We can go and have a look at it. It was a long, long way, but we made it. So we're very happy. Thank you.
Congratulations. That's wonderful news. That's great.
Yeah, thank you, Dr. Glorieux, for sharing that and sharing your wisdom and experience over many, many years. And you taught me much of what I know. So I'm grateful for you and the way in which so many of us.
You absorbed it well.
Thank you.
So we have a nice question from Anna Riabetz Leinhardt that is an important one. She wanted to ask about your thoughts on oral bisphosphonates. What are your thoughts about efficiency of oral bisphosphonates after IV for maintenance phase, for instance?
Yeah, great question. So here's how I think about this. In osteogenesis imperfecta, where the genetic drive while you're growing to return to a low BMD will be best treated with IV therapy because it's more potent. So if you go from IV to oral while you're growing, I'm concerned that you're going to not give the patient what they need to have the full anti-fracture effect. Now, in children with chronic illness osteoporosis, where their chronic illness has resolved, but they have a low BMD that's residual to that, and they're out of the fracture phase, then I will use an oral bisphosphonate to carry them through the rest of their growing years and get their BMD up where I would like it before they exit childhood. But that's a very different situation because the threat to bone health has been withdrawn. So in OI, I persist with IV infusions until the end of growth. It would be interesting to study that though, Anna, to look at what the outcomes are after you've optimized them during the stabilization phase and then put them on oral. But I just think that the bioavailability is so low that I worry that it won't be enough to adequately treat the patient. I also found when I was using oral agents at the turn of the century and doing those trials, as were others, that they just didn't help the bone pain in the same way that the IV agents did. And that's often a major issue for patients with OI, even OI type 1. Patients will often complain of that achy bone pain. So those are my thoughts. But Anna, what are you thinking? Are you starting to try this in clinic?
Yeah, that's actually a small retrospective study that I'm doing with a student who is actually on a call as well, Shreya, where we're looking at kids who, and it is likely type dependent, mild types, age, puberty, right, where how rapidly they're growing, but looking at the effects of oral bisphosphonates and the ones just clinician dependent, specifically residronate, on maintaining the quality of life, for example, fractures, pain, and some do really well on orals. But there are a group of kids, which is probably not surprising, the ones who are more severe types, type 3, or those who with vertebral compression fractures, where we know the phenotype of the bone fragility is just so much more severe. They obviously do not do well. And I've had kids going back on IV therapy, which made sense. But milder kiddos who are happy and did okay and have good bone density, they do relatively well. But we just need more data, of course, and longer follow-up to see how.
Well, thanks for sharing that. You know, it's good to hear what you're trying, what you're thinking. And it's, you know, this is new information because most of us are not doing that.
Right.
I know when I did the alendronate daily versus oral placebo trial, we did not see an increase
I
in
know.
and it was that I thought, oh, that cortical width is so sensitive to anti-resorptive therapy in children with OI. I'm not seeing that. That's what really sort of turned me away in my career from using oral. But, you know, I think that at the end of the day, it's reasonable in milder forms to try it and see what you think. And if you get satisfactory clinical outcomes and which population seems to do okay, then, you know, maybe that's something new for us to understand as we go forward.
And these were kiddos that actually Dr. Duke, as you know, started this approach. And I think it was mainly driven by access and resources at the time. And as you mentioned, it was better than nothing. And for some kids who were not able to continue IV treatment for whatever reasons, or even start that, looking at the oral treatment. So we're trying to look at that. But yes, it's interesting. It's interesting. But I hear you that especially in kids who are more severe, they just don't do well on orals at all.
I often hear about the lack of access to IV or resources because the IV is more than just the IV, isn't it? It's the nursing expertise, it's the on-call physician demand, the first side effects. So,
Leanne, we have a question about periosteotomy, and the question was, do you skip a dose? But I think there are several questions here. how much time are you leaving between the last infusion and an osteotomy? And I think Frank has said wait at least 4 months after and has done some really good work there. But the when to stop before, I think, is still out there. Wondered about your thoughts there.
Yeah, that's a great question. So here's the biology. So bisphosphonates are rapidly absorbed, the IV, obviously, they hone to bone immediately. 80% of the IV drug is taken up by bone, and what is not taken up by bone is peed out within 24 hours. So you cannot actually measure the bisphosphonate therapy beyond 24 hours after giving it. Bisphosphonate therapy hones to areas of high bone activity, and that's why it interferes with osteotomy healing, because the bone turnover is high as part of the healing process. So keeping those principles in mind, then you should not give a bisphosphonate within 24 to 48 hours before an osteotomy, because it's still in the system. I like to wait a week, though. I don't like to cut it so close. So I always say, we're not going to give you a bisphosphonate less than a week before your osteotomy surgery. I don't think we should be skipping doses. We should wait till after there's healing, yes, but I don't think we should skip doses, because with an osteotomy, they're going to have a reduction in mobility, right? And we don't want them to lose bone because they've had surgery and they're not as mobile. So we want to protect them as they go into their surgery in terms of their bisphosphonate therapy, but then wait until there's good healing afterwards. So my rule of thumb is a week, but you could squeeze that down to 48 hours if you were really stuck.
Leanne, talk for a minute about your protocols for stopping. What are your definitions of when it's time to stop? And then follow up once you stop.
Yeah, so I stop once growth is finished and the child is doing well. So there's nothing that I do in terms of any of my decisions that are black and white protocols. And that's why I put in the title of the talk, principles, because I think we always have to be thinking about the principles that are driving the decisions and not just black and white algorithms. But that said, once the skeleton is finished growing, it is less fragile. You no longer have newly formed bone that's treatment naive. You no longer have a risk of a fracture at the interface between the previously treated bone and the treatment naive bone. So it is biologically a good time to stop, provided the child is doing well. And so I want to see that the BMD trajectory is appropriate for age, gender, and sex. I want to see that they don't have undue pain. I want to see that the vertebral bodies have reshaped, and I want to see that they're not having significant fractures, so low trauma fractures or fracture refractures. If the child is doing well, and they usually are, then I stop. And if they're not, then I will continue beyond the end of growth for a little while. If you look at the bone density curve, you will see that the bone mineral accrual continues beyond growth, right? It continues for a few years. So I really am trying to match the bone density accrual to the normal curve. And so for some children, they do continue for a year or two after they finish growth, but usually only if there's still an unmet need. Otherwise, I finish around the time of growth cessation, which is when I see epiphyseal fusion.
And Mike Ober asked you to talk a little bit about pain improvement in Zoll versus Pam. Any thoughts on that?
Yeah. So this is something that gets socialized, right? That one or the other is more effective for pain relief. And I think where this question gets tested the most actually is in chronic recurrent multifocal osteomyelitis, where some people swear that the beneficial effects of pamidronate on pain are better than zoledronic acid. In OI, I don't have the impression that there's a difference in one or the other drug for pain, although I have had patients say otherwise, or I've heard about that being socialized in the OI community. What I think, though, that for me is the most important determinant of the pain response is the frequency of the infusion. I think lower frequent doses are better for pain management than higher, less frequent doses. And that makes sense in a growing child where they're creating this newly formed treatment naive bone all the time. So if I have a patient with OI who has that deep ache, they're not fracturing necessarily, they just say they're aching, and I've ruled out a secondary cause like spondylolysis or spondylolisthesis. I get them into physio, get them stronger, they're still having that aching pain, then I'll put them on a more frequent infusions. So zoledronic acid, I'll go to 0.025 every 3 months or 0.125 every 3 months. And pamidronate, I would go down to every 2 months, although I don't use pamidronate much anymore. So I think frequency matters for pain. Agent, not so convinced, although there may be people on this call who feel otherwise. And I have heard patients say, I think I feel better on one or the other IV agent, but I've never been convinced.
Hannah, would you do me a favor and just pull up that quick slide set? I'm just curious if other people on the call have had this experience, and and the first to confess, yep, just hit the first, yep, and just take the full screen. So like many, I'm embarrassed to say we were a little bit slow. Yep, next slide. To go to bisphosphonates, and this is a 35-year-old young man. He's a college professor, but he did not get bisphosphonates as a kid, and had a spine fusion 11 years ago. And he came in this week, in fact, complaining of back pain. And next slide, please. What I realize is I cannot see his vertebra.
Yeah.
And the stress shielding, I think, is extraordinary. Next slide. You can see them a little bit in the lumbar spine, but barely. And I think this young man is headed towards deep trouble, and would be very grateful. I think, it really implies as a group, we need to be looking hard at these folks who have had spine fusions, because I don't think we've looked at them from this perspective over time. But I would be very grateful for any thoughts people have on potential anabolics here.
Well, can I just make a couple comments? I mean, this slide really speaks to the importance of treatment in childhood, right? Because when you treat vertebral bodies in childhood, you get that beautiful densification of the end plates, and you create a milieu that is better suited to surgery than not treating. And so this individual didn't have the benefit of bisphosphonate therapy during childhood, and now has these very, very radiolucent vertebral bodies. And I hope that the hardware holds. I think that now the question is, what agent would you use? I mean, you're going to be probably limited to some extent by what you have access to. I think that setrusumab is probably coming down the pike, or maybe coming down the pike soon. But I think a bisphosphonate would be reasonable in the absence of your ability to access an anabolic. Eric?
Hi, lovely
Hi.
talk, Leanne.
Eric.
I would say that you have an advantage in some ways in this patient. This patient is not a child. And I would feel completely comfortable with probably any of the commercially available anabolic agents in this patient, but most especially with romosozumab, which his biggest, he does still have a problem because romosozumab, by all accounts, will be off-label because he is not a postmenopausal woman, which is the only population it's actually got FDA label for. But I would, with somebody doing as badly as this person is, I would probably go straight to the strongest thing that we have available.
Thank you. I really appreciate that.
Laura, you didn't mention very much about his specific exam, but and clearly the bones are obvious. But to go back to Kathy's point in the very beginning, this is a collagen 1-opathy. There's a lot of collagen 1 in discs. And we don't know if what he could be experiencing might be discogenic back pain or even discs that are herniating. And at the very minimum, there should be a differential here, and we shouldn't just go, it's OI, it has to be the bone, because there are other things in the spine that can hurt.
Absolutely. And in all honesty, he's somebody who just desperately wants to do well. And frankly, he was lifting heavy weights at the gym. And since I got him to stop doing that, his back pain is a ton better. But that doesn't fix the X-ray, and the X-ray is chilling from my perspective. And that's why I'm just wanted to take advantage of you all being here tonight. Let's be honest, because I think this has changed my point of view in terms of what needs to go into long-term follow-up for our patients.
If I may ask this of Leanne, and Leanne, I said it in the chat, but that was really a tremendous talk, really awesome.
Here,
You know, we're in an adult. You talked about high turnover. You know, this is somebody who's more of a low turnover person. There are different, more of the rarer types of OI that have low bone turnover. And in an era where, at least in pediatrics, we really don't have the antibodies just yet. But what's your approach to the low turnover, low bone turnover, osteoporotic or OI child in terms of bisphosphonates? Clearly, they're not going to respond the same, but how do you approach that? What do you think?
Yeah, it's a great question. So WNT1 and LRP5 are not classic forms of OI, but they're low turnover genetic forms of OI. And honestly, as long as the patient is growing, the low bone turnover does not get in the way of improving bone structure, because the osteoclasts and the osteoblasts are unlinked on the cortical surfaces, which is very different than on trabecular surfaces. So I am not hesitant to use a bisphosphonate in children with low bone turnover states. I do see the best responses in the high bone turnover states, but I'm not reluctant to use them in the low bone turnover states. And even in, Duchenne muscular dystrophy, where we have profoundly low bone turnover prior to starting bisphosphonates, we see benefit from bisphosphonate therapy. But the low turnover osteoporoses, the genetic forms of OI that are low turnover, I think would be ideal candidates, if we can get there, to anabolic antibody therapy followed by anti-resorptive therapy to seal in the effect. Does that resonate with you, Michael?
It does. It's just we're not quite there. And as you know, the trials, as they should be, have specific inclusion criteria, which precludes us really even trying these things in these younger kids. And I have a particular child with, I don't even know what it is, OI type 22 or something crazy like that. That's a low turnover state at the very gracile bones. There's not a whole lot of, place, the endosteum expands and there's no marrow cavity. And it's tricky, right? You'd love to expand the periosteum and do those things. And maybe, a couple of years from now, that's the answer. But I'm just wondering about how you approach it. Because again, a really great talk. I love the way it's not a protocol and you're thinking about everything. And I just like to know how you think about those. I always was like pulling out my hair, and you can see I thought about it for a while.
Yeah, and similarly, OI type 6, right? We haven't figured that out yet. And we use bisphosphonate therapy. It helps, but it doesn't help as much as in classic forms of OI, and that's been published. So I do think that we're headed into a new era. I am hopeful that the anabolic antibody therapy is successful. We came through a very rocky time using denosumab. So antibody therapy, when it's an anti-resorptive, wore off quickly, and the osteoclasts came back with a vengeance and worked even harder than they did pre-treatment. And I do worry with antibody therapy about the skeleton's drive to return to its genetic set point. And so, you know, really obviously looking closely and carefully at the anabolic antibody data, I think that it's going to be interesting to think about how long we treat with anabolic antibodies. Obviously, we need to see the data to understand that. But I would love to, you know, dream about a situation where we have these children who have either high turnover OI and are frequently fracturing despite bisphosphonate therapy, or low turnover OI and not having the same degree of benefits from bisphosphonates. And we give them anti-sclerostin antibody and get them over the rough patch, get the big bones bigger and denser, bigger, and then seal that in with anti-resorptive therapy, such as they've done in adults. So I hope that that's where the field is headed after all these years of servicing these children and knowing that there's a subset that just do not have the clinical outcomes that we're hoping for, at least not the extent to which we're hoping.
This has been extraordinary, and I hate to move us along, and yet we have some wonderful other things to talk about. Kenna, you didn't get my email, but would you just quickly put up for Tracy sort of what's going on with clinical trials? I want to do that really quickly.
Okay, I have to re-pull that up because it exited off. 1 sec, sorry.
Oh, sorry, my fault.
And Dr. Tosi, this is Tracy. I'm pulling an audible here too. I think I was going to give a little information on the impact survey. I can send that out to everybody, but I really want Kenna to share our resources before we end tonight. So I'll just send that information later.
Well, let's keep on going. And all right. Well, so
we'll let Kenna go ahead.
Yeah.
What am I just going ahead with? Just to clarify, sorry, am I doing my talk or?
Yes.
Okay.
Do your talk now.
Yep.
Okay, let me pull up those.
And I'll share the information on the impact survey, which is the global survey that we've done with everybody at a later time.
We'll see how we do.
No, it's good. It's good. It's getting late, so we want people to come back again.
That's always important.
Okay. All right, so I'm Kenna. For anyone who doesn't know me, I'm the manager of health education here at the OI Foundation. And I just want to take a quick moment to talk to you all about our revamping of the OIF's mutual support program that we've been doing this year. So just to give a little quick overview about the mission, since some of you may not be familiar with it, the OIF's mission is to improve the quality of life for those living with osteogenesis imperfecta through research, education, awareness, and mutual support. And all of our programs are deeply rooted in supporting this mission, including the mutual support group program, which fits into bringing OI community members together to provide and receive mutual support from one another, as well as to build common knowledge through education components, which I'll discuss a little further. And for some of you, you may have seen in the adult health toolkit that Tracy mentions how navigating the healthcare environment as a person with or a caregiver of a person with OI is a community effort. However, establishing and connecting with other community members can feel very daunting for a rare disease community. And I hear often within my role how people are having issues or feel that it's impossible or overwhelming to find resources, to make those connections, and especially to find desired support across the country, but also in their geographic proximity to where someone lives. And so one of the major goals of revamping the support group program was to make our country feel smaller, more coordinated, and more connected. So a little bit specifically about the mutual support program is that the OI Foundation recognizes the value of creating a space for our constituents where they can share their personal experiences and both receive and provide support. For many years, the OIF support groups were state-based and they met in person. However, with COVID and also advances in technology, some groups started to meet virtually. And we looked at it when we were revamping it, and we wanted to make this program more accessible for everyone in the community. And so we've now expanded this program to ensure that everyone in the US, no matter where they live or their ability to travel, has the opportunity to connect with others either geographically or by interest. And so the program will now be primarily virtually based, and it includes regional based support groups, which those just launched this spring. And eventually it will also have affinity groups, which will be added at a later date. And so this slide just kind of breaks down those components of the two types of groups. So we have the regional support groups. And since those groups are have multiple states within each region, we have made it where there'll also be state-based contacts, and those are people in the OI community that people can reach out to if they're trying to reach directly someone within their state for mutual support. And they'll also be able to help regional support group leaders learn and build their knowledge of resources in each state, since, as I said, some of these regions contain 10 or so states. And then at a later date, we do want to add in affinity groups. So those could be things such as parents of children with OI, young adults, things that are more specific to a certain population. And the OIF's mutual support group program, the main component of it is peer support groups, where really our hope is that people who share a common experience and interest or concern can come together to provide mutual emotional and moral support for one another. The support groups aim to foster a sense of community by providing members with a safe place for individuals who share similarities to talk with each other and others who truly understand what they are experiencing and can provide insight through their own personal experience. And our hope is that by engaging with a peer support group, participants may feel less isolated, more empowered, and equipped to advocate and manage aspects of their own care and experience a more positive outlook. That being said, here are just a few of the specific goals that the program has, which includes providing a sense of community, increasing awareness about OI, promoting living well with OI, and helping individuals and families connect with the OIF resources and services. So as I mentioned, we've right now are focusing on the launch of the regional support groups. And so those contain 5 different geographic regions. So the Northeast, the Southeast, Midwest, Southwest, and West. And with the assistance of OIF staff, these are run by 2 OI community members, with the exception of the Southwest, which only has 1 regional support group leader. And then, as I mentioned before, those leaders are also being supported by state-based contacts to help us really understand what is occurring in each state. And this shows just a breakout of what states are within each region. And this information is also on our website, so that can be accessed there. But if you want to take a moment to look at those to see where your clinic or practice is located, so you can let your patients know, that would be great. All right. And then just to quickly clarify what the OIF regional support groups are specifically, it's really a place where we are aiming for the support groups in a given region to provide a safe space to share, learn, and build community through socializing. So sharing will allow participants to talk about their experiences and feelings and offer each other mutual support and encouragement. Education can occur when group members receive new information on topics of interest. So this can include OIF Foundation resources, our videos, having speakers talk on specific topics. And these topics can be related to OI itself or any area associated with living with OI. So for example, school, recreation, employment, insurance. And then socializing helps to build community and make the community members in multi-state regions feel significantly smaller and helping community members to feel that they're not alone. And this can be done in a variety of ways, including game nights, social hours, etc. And then the program is really aiming to connect and foster that sense of community, but it's also hoping that we can gain a better understanding of the resources that we have nationally, but also locally, so we can really help start to provide that information to our constituents. How can you all help with us reaching the OI community about this program? Currently, the OIF has been letting our constituents know about this program through our social media, targeted email blasts, and our newsletters. However, we know that there are community members who are not actively involved with the OIF or may not even know about our organization. So as providers who are working with the OI community, we would love it if you are able to, one, let your patients know about this program and connect them to the OIF's social or our website page for our social networks, which I'll put in the chat after this. And that website is where you'll find information such as the contact information for each support group leader, as well as a list of upcoming scheduled meetings. Also, if you yourself would like to receive information about upcoming meetings in your clinic or practice's region, please let me know. And I'll also put my email in the chat as well. And I'll add you to a list where I can start to send you that information as well, so you can disseminate it to your patients. And thank you for listening to that, because this really is an important program to us. When I started, one of the things I said was how I really hope to bring communities together. And so I'm really excited to see that this program has been launched and the impact that it will have. Thank you.
Terrific job, my dear. And I think we've all had the experience of either the family or the kiddo who thinks they're alone, that no one else is out there. They've never met anyone with their disorder. And I'm very excited. And I hope that we can do everything to build these groups up to the very best they can be. So thanks so very much for that effort.
Thank you.
And to everybody on the call tonight, thank you so much for being here. This has turned out to be one of the great fun things that we're doing in terms of uniting the clinics. I hope you'll share this opportunity with other clinical groups that you know. We estimate that there are close to 60 clinics in the US, and how do we get them all talking to each other, sharing the information is a tough call. And we welcome your ideas for other things we can do, but for right now, welcome and thank you. And we'll see you in the fall. Take good care.
Thanks, everybody.
Thank you.
Bye-bye.